Hello, class. Welcome to Flourish Nursing Academy. We'll be discussing hypertension. Hypertension is defined as a persistent elevation of the systolic blood pressure, BP, of 140 mmHg or greater and or diastolic BP of 90 mmHg or greater, taken at least twice on two separate occasions. Types of hypertension. 1. Based on blood pressure readings. Pre-hypertension. Systolic blood pressure of 130 to 139 millimeters of mercury. Diastolic blood pressure of 80 to 88 millimeters of mercury. Hypertension stage. I. Systolic blood pressure of 140 to 159 millimeters of mercury. Diastolic blood pressure of 90 to 99 millimeters of mercury. Hypertension stage 2. Systolic blood pressure of more than or equal to 160 millimeters of mercury. Diastolic blood pressure of more than or equal to 100 millimeters of mercury. Hypertension stage 3. Systolic blood pressure of more than or equal to 170 millimeters of mercury. Diastolic blood pressure of more than or equal to 110 millimeters of mercury. Hypertensive crisis. Primary or essential hypertension. Risk factors: A. Aging. B. Family history. C. Obesity. D. Smoking. E. Stress. AF. Excessive alcohol. AG. Hyperlipidemia. H. Increased intake of salt and caffeine. 2. Based on causes. Secondary causes of hypertension include parenchymal kidney disease, sleep, a drug-induced drug-related, for example, oral contraceptive, steroid, non-steroidal anti-inflammatory drugs, cyclooxygenase 2 inhibitors, erythropoietin, Cushing syndrome, parathyroid disease, coarctation of the aorta, acromegaly, pheochromocytoma, thyroid disease, primary aldosterone, primary induced. 3. Because of increased production of hormones and enzymes during pregnancy. Isolated systolic hypertension, ISH, is defined as systolic blood pressure of greater than or equal to 140 millimeters of mercury and diastolic blood pressure less than 90 millimeters of mercury. Common after the age of 50, it carries with it a poor prognosis. Isolated office hypertension is characterized by an elevation in clinic blood pressure, but normal home or ambulatory blood pressure values. In these subjects, the clinic blood pressure is persistently above 140 over 90 millimeters of mercury, but the home or daytime ambulatory systolic all over diastolic blood pressure measurements are lower than 135 over 85 millimeters of mercury. Patients with masked hypertension have normal clinic blood pressure but elevated daytime ambulatory or home blood pressure level, greater than 135 over 85 millimeters of mercury. Prognosis of masked hypertension is worse than isolated office hypertension. Hypertensive crisis. A hypertensive crisis is an acute and life-threatening condition requiring immediate reduction in blood pressure. Emergency. Treatment is required because target organ damage, brain, heart, kidneys, retina of the eye, can occur quickly. Death can be caused by stroke, kidney failure, or cardiac disease. An extremely high blood pressure, systolic over 180 millimeters of mercury and or diastolic over 120 millimeters of mercury. 1. Headache. 2. Drowsiness and confusion. 3. Blurred vision. 4. Changes in neurological status. 5. Tachycardia and tachypnea. 6. Dyspnea. 7. Cyanosis. 8. Seizures. Maintain a patent airway. Administer antihypertensive medications intravenously as prescribed. Monitor vital signs, assessing the blood pressure every 5 minutes. Monitor neurological status. Maintain bed rest, with the head of the bed elevated at 45 degrees. Assess for hypotension during the administration of antihypertensives. Place the client in a supine position if hypotension occurs. Have emergency medications and resuscitation equipment readily available. Monitor IV therapy, assessing for fluid overload. Insert a Foley catheter as prescribed. Monitor intake and urinary output. If oliguria or anuria occurs, notify the private home care provider, PHCP. Pathophysiology. 1. Increased peripheral resistance. The narrowing or stiffness of small arteries and arterioles increases resistance to blood flow. This forces the heart to work harder to pump blood, elevating blood pressure. 2. Overactivity of the sympathetic nervous system, SNS. Chronic stimulation of the SNS causes vasoconstriction, tightening of blood vessels, increased heart rate, and increased cardiac output. This contributes to elevated blood pressure. 3. Renin-angiotensin-aldosterone system, ERAAS. Dysregulation. The RRAAS helps regulate blood pressure and fluid balance. Overactivation leads to vasoconstriction via angiotensin II, sodium and water retention via aldosterone. Both contribute to increased blood volume and pressure. 4. Renal impairment. The kidneys may fail to excrete sodium properly. Sodium retention leads to fluid overload, resulting in increased blood volume and pressure. 5. Endothelial dysfunction. Damage to the inner lining of blood vessels. Endothelium reduces the production of nitric oxide. This impairs vasodilation and promotes vasoconstriction and inflammation. Clinical features. Sometimes high blood pressure does not cause any symptoms, so it is known as a silent killer. In some patients, the symptoms will develop like severe headache, blurred vision, dizziness, fatigue, confusion, epistaxis, chest pain, shortness of breath, irregular heartbeat. Diagnostic evaluation, history collection and physical examination, medical history of diabetes, mellitus, complete blood count, chest X-ray, electrocardiogram, lipid profile, uric acid, urinalysis, renal function test, management of hypertension, non-pharmacological management, body mass index or weight. Achieve a weight loss of as little as 1 kg from baseline to reduce blood pressure by 1 mm of mercury systolic blood pressure. Salt intake. A reduction in salt intake to less than 2 grams per day or less than 5 grams per day of salt in adults results in a decrease in blood pressure of 7.8 over 2.7 millimeters of mercury with hypertension. Alcohol. Refrain from alcohol intake. Advise the patient who insists on drinking to consume no more than or equal to 2 drinks per day. Exercise. Advise patients to perform physical activity, e.g., moderate intensity aerobic exercise of at least 150 minutes per week. Diet, which includes a diet rich in fruits, vegetables, and dairy products with reduced saturated and total fat. Smoking. Stop smoking to reduce overall cardiovascular risk. Relaxation. Encourage the patient to manage stress, although evidence on relaxation interventions has not been convincing. Dietary potassium. Intake. A meta-analysis has shown that increased dietary potassium intake reduces BP in adults with hypertension without adverse effect on blood lipid concentrations, catecholamine concentrations, or renal function. It helps the kidneys to inhibit the sodium reabsorption.